Hello, good morning, good afternoon, good evening to all the speaker chairs and a wonderful audience in different parts of the world. Welcome to the ACNS webinar. The speaker for the first session of today is our honorable guest, who is a world-renowned endovascular neurosurgeon from Japan, Professor Michihiro Tanaka. Professor Tanaka is the president of the World Federation of Interventional and Therapeutic Neuroradiologists, as well as the director of neurosurgery and neuroendovascular surgery at the Kameda Medical Center in Tokyo, Japan. He also holds a position of the advisory committee member of the Ministry of Health, Labor and Welfare, Pharmaceuticals and Medical Devices Agency in Japan. He did his fellowship and work as an assistant and associate professor for 6 years in Zurich with Professor Van Vanis. His clinical interests are focused upon the management of intracranial aneurysm, AVM, Dural AVF, head and neck tumors, and spinal cord vascular malformation. He's an indispensable speaker at all the major leading endovascular conferences around the world, and he's also a noted author with several publications in various peer-reviewing journals. We are extremely honored to have him today with us as a speaker, and today he's going to talk about embryological consideration in Dural AVF. The speaker for second session today is our guest from China, Professor Liu Jingchao. Professor Jingchao is a doctoral supervisor, head and chair of the Department of Neurosurgery at Shandong Provincial Hospital in China. His clinical interests are neuro-oncology and functional stereotactic neurosurgery. He has currently his research focused on translational medicine of glioma and AQP4. He is also noted author, has published more than 40 peer-reviewed SCI papers and other renowned peer-reviewed journals. The chair of the first session today is our faculty from Rome, Italy, Professor Simone Pecillo. Professor Pecillo is a specialist in neurosurgery, adjunct professor at the San Camilo International University of Health Sciences, where he's the chair of endovascular neurosurgery. He's a member of vascular section of ACNS and director of the fellowship program in vascular and endovascular neurosurgery. He's also a visiting professor at the Department of Neurosurgery in Hyogo College of Medicine in Japan. He has performed more than 1,000 endovascular neurosurgery procedures in Italy and abroad. He's the author of over 80 articles in international journal, including European guidelines on the treatment of cerebral aneurysm. Reviewer for the most important international neurosurgery journal and author of 3 books on neurosurgical pathologies. He has participated as invited speaker at numerous neurosurgery congresses in Italy and around the world. We are extremely honored to and grateful to him for accepting our invitation to chair the session today webinar. The chair of second session today is our faculty from the USA, Professor Alisira Mansouri. Professor Mansouri is an assistant professor at the Department of Neurosurgery at the Penn State Cancer Institute in Pennsylvania, USA. His clinical interests are focused upon brain cancer trials, surgery of brain tumors, and epilepsy surgery. He scores the international publication and book chapters. We are grateful to him for accepting our invitation. On behalf of the Educational Committee of ACNS and the President, Professor Zuko Kato, I would like to welcome both the speaker and chairs of the and the audience to this online platform of ACNS webinar. We are also extremely thankful to Professor Subin for broadcasting the webinar on WeChat channel in China. Dr. Liu Bun Sang from Malaysia is my co-host today. With that introduction, I would like to hand over this online podium to our first chair, Professor Simone Pecillo. Professor Pecillo, please.
Hello, good morning. Good morning, everybody. It's a great honor to be here with you. And it's a great honor also to introduce my friend Michihiro Tanaka from Japan. As you have already mentioned, Professor Tanaka is a great expert in the neuroendovascular procedures and in neuroanatomy and embryology as well. I think that his lecture will be very important for everyone who is doing endovascular procedures. And I think that it's very important to start from the anatomy to to better understand what we have to do. And in particularly, today, Michiro will discuss with us about the embryological consideration of dural arteriovenous fistula. I think that this is very an important topic, and I'm very happy to introduce you, Michiro. So, Michiro, thank you so much, and the
Thank
stage
you.
is yours.
Thank you so much, that Simone and also Dr. Hugh Farms and also Professor In Chao Lius, and it's my great honor and a great, pleasure to be invited here and in the Saturdays in the morning for you, for me in the night to discuss with the embryological considerations of the dural AVF is a bit, peculiar because we neurosurgeon or neurointerventionalists usually do not pay attention about the embryological aspect of this, disease, but if we are looking for, that the details of this dural configurations, that it is quite important to see. So it's my honor to be here and my pleasure to discussing about the embryological considerations. What does it mean, the embryological considerations? So we will start with the anatomy and embryology of the dura mater encephaly, which is the place where the shunt is formed. And also, maybe some of you are not so familiar with the concept of the neural crest and the mesoderm in relation to the dural AVFs, and I'm happy to share my small experience with some of the case presentations. So I have no specific COI. So as we know that the brains, breaching veins, subarachnoid space, and this is the dura propria. But in the reality, that in between the subarachnoid membranes, so-called arachnoid space, and the dural membranes, we're gonna have a so-called dural border cell, which is a very important architecture in the formations of chronic subdural hematome. But this time I will not dealing with the dural border cell layer because our discussion tonight is today is dural AVF. So the space where the shunt is forming is dura propria and periosteal dura. So dural membrane is not one single layer. The dural membrane is consists from the two layers. One is a dura propria, which is faced on the brains, and one is a periosteal dura, which is faced on the bony structures, of course. And in between this small word, we have leptomeningeal epidural veins, so-called interdural veins, and osseous epidural veins, which is sometimes connecting with interdiploic veins or emissary veins. So what about the classifications of the dural AVF today? So we're gonna have lots of historically there are many of anatomical or topographical classifications of dural AVFs since 1973. So Professor Amonov started to describe the concept of the classifications of dural AVFs, and Awad, Mironov, and Professor Moret, Guy Placir. And as we see that many of you know that the Borden classifications and the Conyard's, Christophe Conyard classification. But this Christophe Conyard classification is certainly the modified of the Jinjan's classification, which is very important. For instance, very early period of time, the 1975, that just the lateral sinus, cavernous sinus, superior longitudinal sinus, which might be corresponding to the superior sagittal sinus, tentorial falcine, and convexity meninges. So in the classification of the carotid cavernous fistula, you see that a bunch of the reporters to try to understanding the or classify those of the complex disease, and but however, all these classifications, most of the classification is based on the hemodynamic or angiographical classification. But in 2008, the group of Pierre started to do the anatomical embryological classifications. And recently, I proposed the completely different types of the classification, which is anatomical embryological classification. Or I would say my proposal is not classification, it's just categories. But as we know that the Borden classification, the corneal classification is very used there to predict the natural causes of the disease. Therefore, if you have a corneal type 1, that usually not indicated for the interventions, but corneal type 2B or 2A plus B and other types is considered as an absolute indication for somehow neural intervention. So hemodynamic classifications, anatomical classification, but the original idea was already appeared in 1978, the group of the Jinjans and his colleagues, Jean-Jacques Meroulan, and this is a really, really significant textbook. And in this textbook, you may see type 1, the typical pure meningeal arteriovenous AVF, without cortical venous reflux, type 2 with a cortical venous reflux, and type 3 if you may have this kind of varix or venous lake, which is a strains and stress of the pial venous systems, of course, and this is definitely that the future the risk of the hemorrhage or neurological deficit related to the dural AVF might be very high. And the type 4 is a purely meningeal arteriovenous fistula draining directly into cortical vein, which is a tentorial dural AVF and anterior cranial base, which is usually the cribriform plate, and so on. So this insight and the predictions is really, really helpful to understand the future risk of the hemorrhage and so on. And 2014, one of my friends, that he is also was a group of the Zurich University, and he categorized that more meticulous categorized with based on the breaching veins and or if the shunt is close to the breaching vein, that it might be more significant venous cortical reflux to the parenchyma. And if the shunt point is a little bit far away from this breech vein, for instance, transverse sigmoid sinuses or cavernous sinuses, usually that the risk of hemorrhage is not so high. So according to his bit complex concept, this is a so-called direct type of shunt or a breaching vein shunt. And if the direct type of the sinus and the non-direct, non-exclusive strain to the venous stress, the risk of the hemorrhage is not so high. But if the shunt point is close to the breaching vein and directly 100% of shunt flow reflux to the breaching vein and the pial vein without draining to the main sinuses, of course, that the risk of the future hemorrhage is very high. So after his study, you see that he categorized 8 types of the dural AVF, which is a bit complex. However, there, that according to his classifications, you see on this group, the close to the breaching vein, that shunt point is very single, shunt flow is not so high, but the neurological deficit and aggressive type hemorrhagic risk is so high. This is very clearly demonstrated. For instance, here is a typical transverse sinus dural AVF and no significant leptomeningeal venous reflux. just a little bit, the inferior petrosal sinus reflux. So those group is usually just patient complains tinnitus and no risk of the hemorrhage because no significant venous reflux on the pial system. So therefore, this is a non-direct and non-exclusive and non-significantly reflux. So his classification is a bit makes sense, but bit too complex. Therefore, I started to categorize completely another concept, which we published in the 2016 and the 2019. You see, our dural membrane is very simple. You see that as I showed, the periosteal dura, this is the black one, and the dura propria, this is the green one, and falx tentorium is, of course, the two dura propria. But convexity is consisted from the one part is periosteal dura, and the inner surface is a dura propria, of course. And look at here, tentorium cerebelli is also two layers of dura propria. And interesting to say here, foramen magnum, let's say here, and the periosteal dura is turning around and coming back to the periosteal dura on the surface of the skull, which means at the level of the spinal cord, there is no dura propria. Actually, there is a small dura propria in this on the surface of the vertebrate bony structure, but there is a space. Therefore, I would say that the spinal cord is consisted only from dura propria. Tentorium cerebelli only from dura propria. Falx cerebelli only from dura propria. Okay, so it's so simple. Inferior sagittal sinus, of course, only consisted from dura propria. So this dura propria is formed in the level of the week 12, which is still just after organo development of the embryonic state. And here, this green line is corresponding to the only consisted from the dura propria, I would say. So here, of course, as you know, that here is a cribriform place or a cristagari or olfactory group is this part is the dura is consisted from the dura propria. Then, what is a neural crest? The neural crest is discovered by the Professor Wilhelm Hess in the late of 19th century. He started to exclusively studies about cell migrations. So we have a mesoderm, endoderm, ectoderm, and neural crest. So therefore, neural crest is considered as a fourth germ layer, which is initiator and a promoter to create a bunch of tissues. For instance, meningeal dura mater and the neural the facial bony structure and a bunch of you see that the urogenital innervations and the dorsal root ganglion. Those of you know that the significant neural system is made from neural crest, which he discovered around 100 years ago. So many our cranial nerve is coming from also neural crest, and that this neural crest is really looking so here this kind of thing. Then what about in the experimental model? Here the rat and this blue one is a immunostaining of the neural crest cell. If I look at carefully this experimental model, tentorium cerebelli and falx cerebelli is staining with a neural crest immune staining, which means it's coming from the neural crest. On the coronal view, the magnified view, falx cerebelli is consisted from the neural crest. However, in the parietal bone, look at here, is a red one, is made from the mesoderm. Another experimental model showing also that this green one is indicating of the neural crest-oriented tissue, but this parietal bones and some of the dural matter is made from the mesoderm. So the dural membrane is, some part is coming from the neural crest, some part is coming from the mesoderm. This is a recent experimental model study. So most of the dura propria might be derived from the neural crest, and the parietal periosteal dura is coming from the mesoderm. You see? So in the another experimental model of chicken, no? So this is a bony structures, the frontal part, so-called frontal bone coming from the neural crest, the parietal bone and occipital bone coming from the mesoderm. In the mouse is a similar situation. So this is a coronal suture is a border zone between the neural crest and the mesoderm in terms of the bony structure. However, in the midline structure, the midline structure is really coming from the whole these things. You see the neural crest, and here is the neural crest. So I would say parietal bone, mesoderm, okay, but midline structure and frontal bone coming from the neural crest. For instance, the recent studies about the meningioma, the pathohistology or malignancy and the gene expressions of the meningioma is also varies from the place to place. If the meningioma is localized on the part of the neural crest dural matter, and the malignancy is a bit higher than the meningioma originating from the mesoderm. Those of study is recently well published. So I started to first divide it into the, this is I published almost 10 years ago. The green one is the neural crest, and the red one is a paraxial mesoderm, and the yellow one is a dorsal mesoderm. But anyway, red and yellow are mesoderm, and the green one is a neural crest. Then I categorize the green one, the neural crest oriented. Let's say this is a falx and a tentorium. And the spinal cord is also made from neural crest, as I mentioned. So very interesting to say. A bunch of those cases, olfactory group belong to the here, tentorium, neural crest oriented, falx, neural crest, and the spinal cord. Then more than up to 90% of the cases are male, man, especially 50 years old, 60 years old, 70 years old man is affected this territory, this which corresponding to the blue bar, and the red one is a female. For instance, carotid cavernous fistula, sigmoidosinus dural AVF, anterior condylar conference, which is belong to this red one, is this the ventral so-called mesoderm group, and here is also mesoderm group is a predominantly can be seen in the female dominancy. So, and of course that Boden type 3 malignant cause of the dural AVF is strongly corresponding to the neural crest oriented group. So nowadays, for me, the dural AVF only two types. One is coming from the neural crest oriented dural AVF if the shunt point is located falx, tentorium, falcotentorium, olfactory groups, and the spinal cord. Those of things, for me, neural crest oriented, malignant cause. And here, the mesoderm oriented is cavernous sinus, cribus, anterior condylar conference, sigmoid sinus, and lateral part of transverse sinus. Is all this thing is relatively benign unless it is thrombosed in the main sinuses. Then This is belong to the mesoderm. So nowadays, for me, the green one, pharynx and anterior cribodiformal plate, and part of the anterior crinoid process, and the lateral sphenoid wings, and pharynx and tent here, and of course also inferior pharynx, which is a infratentorial pharynx, midline structure, are neural crest mesoderm. They look at this one, the neural crest oriented, nearly 90% male, and more than 90% cortical venous reflux. Therefore, as a consequence, that the clinical cause of natural cause of this disease is a very malignant compared to the mesoderm oriented. And in this mesoderm oriented, female is near up to 70%. That is my simple classification. So this green line is a malignant cause, and this red line is a simple. So let's say 69 years old, progressive paraplegia, 6 months, and you see that the flow void on the T2 weighted imagings. And here is a MRI showing the abnormal dilatations of the spinal canals. And the former hospital couldn't find, they did the spinal angiography, but all spinal angiography were negative. Then patient was sent to the neurology and given the steroid for a couple of weeks, months, but nothing happened. That the deteriorating and coming to our institute, and we did the angiography. First, we started not a spinal cord, but I started with an internal carotid angiography. Then the shunt is there, easy. So don't misunderstanding that if you have dilatations of the spinal cord venous systems, not only spinal angiography, but also do intracranial. You see that the external carotid injection showing that, very small shunt, but significantly draining to somehow breathing vein. And here is a transverse pontine vein, posterior lateral pontomesencephalic vein. Here is a pontomedullary junctions and draining to the spinal cord, which is definitely, you see that the very small, so-called corneal classifications are, they say type 5, but this is a typical orientation. So yes, this case was a very old case, and at that time we had no facility to approaching to this shunt endovascularly, so we decided to go to the microneurosurgery. Here is a microsurgical observations of the here indocyanine greens. You see the early venous fillings and initial foot veins, bridging veins is here, is early venous fillings, and here is of course that the superior cerebral artery. So this place is a cranial nerve fifth. So this is an infratentorial approach, and here is the petrosal veins is fully affected with the venous hypertensions because of this small shunt. So if you understand the angio architecture of this shunt place, you see that this is a very famous Alberto Lawton Jr. microsurgical microanatomy. Here, initial foot veins is corresponding to the here vein of cerebropontine fissure, and here is coming to the vein of middle cerebral peduncle. And here is, of course, transverse medullary veins. And here is a vein of pontomedullary sulcus and coming to the anterior medullary vein. So what we did here, is very simple. After investigation with the indocyanine green, coagulations, and just put some small clip. And here, initial foot vein is completely occluded. This is a confirmation with the indocyanine greens, and they confirm that no early venous filling to the pial systems. Here, before embolization, this is after embolization. Again, 66 years old man, okay? Incidentally detected. Here, after embolization of the anterior choroidal artery or ischemic aneurysm embolization, but incidentally we detected here either early venous fillings supplying from the anterior ethmoidal branch from the ophthalmic systems. So this is early venous fillings and the breaching veins and draining to the superior sagittal sinus. So you see that the superselective angiography from the ophthalmic systems is more clearly showing that the shunt point is locating on the crista galli, or let's say cribriform plate. Therefore, this is a durapropulia, neural crest-oriented, 66 years old man, and 100% of the shunt flow reflects to the pial vein or breaching vein. That which meaning that this is potentially the high risk of the intracerebral hemorrhage in the level of the olfactory groove or frontal base. And here is a selective angiography and the high resolution cone beam CT. You see the cribriform plates, anterior ethmoidal vein, meningeal system artery. Here is a shunt point. And this is the initial foot veins, is continuation to the frontal lobe. I hope that you appreciate, you can enjoy that this high resolution cone beam CT. Here is the breaching veins. Still, this is breaching veins, and here is the entrance, the superior sagittal sinus. The whole this long course of the breaching veins is affected with venous hypertension. Therefore, that this is the definitely indications. Here, initial foot veins, anterior ethmoidal artery, and here is the shunt point where located on the cribriform plate. So, before, many years ago, we do clipping, just clip here. That is a definitive solution. But nowadays, we're gonna have a very nice microcatheter, distal access catheter, transvenously approaching here, and the microcatheter is approaching, and just few platinum coil is enough to eliminate the initial foot vein, and this is the immediate after embolization. The shunt is gone, and the ophthalmic system is, of course, intact, and the patient is completely free from these types of the dural AVF. So, in the case of the superior sagittal sinus or inferior sagittal sinus dural AVF, we have also very significant disease here. You see, this is early venous filling, which is difficult to understand sometimes. Oops. Here is the patient presented with a 42 years old man. Again, it's a man. This is very keyword. And here, the affected with high venous hypertension and intractable epilepsy and headache. And here in the even infratentorial system is pathologically dilating of the horizontal fissure of the venous systems. Here is our 4D multi-channel CT showing the early venous fillings and very complex, but more easy to understand that you see that this is a selective angiography, external carotid angiography. The shunt point is very small, but 100% of the shunt flow reflects to the cortex on the left parietal region. Here is the same on the contralateral. And this is the internal carotid angiography, also showing somehow the peculiar or bizarre appearance of the normal cortical veins in the inferior parietal system. This is so-called pseudo-phlebitic patterns, which is because this part is also affected with a venous hypertension. So this is an internal carotid injection and normal cortex, and here is external carotid injection. Here is the abnormally dilated to venous systems, but this is a pial vein. You see here is there is completely different system they use. in the lateral view, internal carotid injections, normal parenchymal venous systems. Here, external carotid injections, pathologically dilated venous system. So if you could occlude the shunt, then all this venous drainage system is not necessarily for the draining system of the normal parenchyma system. This is very important information for the embryolations. Here is again, so we decided to do that embryolation, but in order to save the time that just I show that the technical aspect, because this is already the middle meningeal artery super selectively approaching. But you see the tip of microcatheter is very close to the shunt point, and you see that the pathologically dilated vein can be seen only. So I hope that you see this one here, the balloon, the inflation, external carotid system, to give us, flow control. So if you inflate the bilateral external carotid, then your glue injection is more easier. So you can have a good flow controls and relatively, that the concentrated glue is enough. Of course, that if you are familiar with Onyx, of course, the Onyx is a wonderful option. But for us, at that time, that we prefer to give in the glue and full flow control with the balloon inflation, the balloon guiding catheter. So here is the tested injections. We always check that the inflations, then we started giving the glue, but some of the glue is through and migrating into the, here is a frontal Sylvian fissure, some of the glue is through, but do not hesitate to inject, because all this venous system is not used for the normal cortical vein, which we show here, continuously glue injections. And here is again the glue and the injections here, and here is exactly what we did. And immediately after embryolations, you see that this is a glue cast. But the most important thing is not the angiographic outcome, but also that the most important things are immediately after the MRI, that that the high flow shunt and the cortical venous reflux is gone, and no significant ischemic transformation, of course, and no edema. And here is the before embryo. Here is a glue cast and partially thrombose, and the patient is doing well. So, in order to conclude that this I have to stop 10:20. So, okay, I have a short 20 minutes. So, another patient, sphenoid wing, 86 years old, intractable epilepsy. You see the whole frontotemporal regions, including the insular cortex and the medial temporal regions, and the amygdala are significantly signal alterations of this on that flare. MRIs, and this is a diffusion-weighted imaging showing no significant ischemic changes, so it's not a stroke. And here, either you see that the T2 weighted imaging, again, that the froboid, abdominal froboid in the territory of the frontotemporal regions. And here is a flare, as we see that here is a signal alteration significantly. So let's look at the internal carotid angiography in the contralateral side. You see somehow that the transmeningeal supply and the early venous fillings from the left superficial middle cerebral systems. And my young colleagues believe this is the external carotid and the AQP4 right external carotid injections, showing that somehow the contribution through the meningeal system, through the ascending pharyngeal systems, and going to the left somehow lateral cavernous sinus. Therefore, our young colleagues consider, okay, this is a typical carotid cavernous fistula, but for me, it's not the typical carotid cavernous fistula formation because the shunt point is very small. initial foot vein is lateral, and there is no significant reflux into the cavernous sinus, even either superior orbital veins and also inferior petrosal sinus is not affected with this shunt, which is quite peculiar, quite unique. And how about ipsilateral internal carotid injection, showing also that somehow the pseudo phlebitic patterns, but no significant cavernous sinus filling. And here in the lateral view, you see that the meningohypophyseal trunk or inferior lateral trunk and ophthalmic system may contributing to the shunt, but no reflux to the inferior petrosal sinuses. And here is external carotid systems showing that the initial foot veins in the level of the lesser sphenoid wing, and directly draining to the superficial middle cerebral veins, or cerebrium venous group. In the lateral view, you see that here is a shunt point and here's the initial foot vein. And the most important thing is what we do is this is ascending pharyngeal systems. You see that the contralateral hypoglossal branch, and here odontoid branch, and here is the lateral and medial clival branch, and going to the close to the lateral clival portion, but not entering to the cavernous sinus, but going to the small point we are locating on the lesser sphenoid wing on the left side. But our young colleagues try to, or understanding to the transvenous approach, they do the try to venous approach, but they couldn't entering to this shunt point, of course, because completely different compartment, very close, but just lateral to the cavernous sinus. But more important information, this is a middle meningeal artery, superselective injection, showing the whole systems. You see that the very small shunt and directly draining to the superficial middle cerebral veins. So this is a sphenoparietal sinuses, and in the lateral view is the same. But most easy to understand is just look at cone beam CT. We have now very elegant type of the cone beam CT. You see here is a selective injection of the external carotid systems. And you see that here is the initial foot veins. All this zigzag shape is just dilatations of the abdominal cortical veins. But here, all the terminal feeding arteries coming from the meningeal systems, entering to the one point and draining to the superficial middle cerebral veins. And here you can appreciate also whole thing with the high resolution cone beam CT, just one point. This is a selective angiography from the ascending pharyngeal systems. Here is the external carotid. So this is a typical dural AVF, but not carotid cavernous, but lesser sphenoid wing. So a little bit lateral aspect here. Our microcatheter from the middle meningeal artery, recurrent meningeal artery. Then again, this is a superselective angiography from the microcatheter, marathon microcatheter at that time. The tip is placed on the recurrent meningeal artery from the left side, and selective angiography showing that this is the terminal feeder here, initial foot veins here in the draining system. Therefore, what we did here is a onyx injection. This is after onyx injection. Here is an injection, and of course, after onyx injection, transarterial embolization enough to eliminate whole shunt. And here is what we did outcome that just onyx cast, the onyx embolic material cast without no contrast injection, showing that the lesser sphenoid wing is completely eliminating, and initial foot vein is here, is filled with embolic material, which is most important aspect in terms of the complete obliterations of the dural AVF. And again, here is another volume rendering data. Okay, it's moving. So here it's just the Onyx screw cast. So, and for my classifications, the place of this screw is placed on left side here. So lesser sphenoid wing is also corresponding to the neural crest oriented venous system. Therefore, this AVM is belong to this group. And additional most important evaluations of the dural AVF is not angiographic outcome, but also that the flare, yeah, before embryolations, intractable epilepsy, seizure, but just few weeks after embryolations, you see all this intracortex medial temporal and temporal signal alteration is now recovered, and the patient is now good enough. Transoral anti-epileptic agent is enough to control his epilepsies and recover. This is a typical carotid cavernous fistula. This is a lady, around 60 years old lady. The shunt point is in the cavernous sinus, of course. Here, the external carotid, or almost superselective ascending pharyngeal induction. In the lateral view, you see that the whole cavernous sinus is venous hypertension, severe ophthalmic veins, and the inferior petrosal sinus, and the connection to the superficial middle cerebral veins, of course. But what I want to show here is do bilateral angiography, not external carotid, but the ascending pharyngeal, in order to identify the shunt points where. So for us, easy to understand here, odontoid branch, and this is odontoid connections, and here is a hypoglossal branch on the left side, on the right side, and the lateral clival branch contributing to the 1 point. But in the meanwhile, also always we do bilateral indictions of the ascending pharyngeal artery and high resolution cone beam CT. Then all of us, easy to understand where is the shunt. The shunt is located under posterior crinoid process in the bony structure, because all this terminal feeder either in the bony structure of the clival bone. So this is a transosseous. Therefore, some of the people say this dural AVF is so-called osteodural dural AVF, the osteodural shunt, which is fully corresponding to the mesoderm-oriented dural AVF. And also, in this situation, that the sinus packing is the best solution. Therefore, the transvenous approach and venography affected venous systems. You see this bridging veins, and this basal vein of Rosenthal. Here is the lateral ponto mesencephalic vein, transverse pontine vein. Here is a bridging vein and draining to this superior petrosal sinuses. Easy to understand. So, combined with venous informations and arterial information, and do the cone beam CT. So let's play with anatomy, and let's use your microscope, which is a high resolution cone beam CT. For neurointerventionalists, it's a kind of microscope for, and here the arterial phase on the left side and the venous venography on the right side fuse in your brain, so the easy to understand where the shunt point is here. So therefore, this shunt point is definitely corresponding to the left posterior crinoid process. And after introduction of your microcatheter transvenously, confirm your tip of microcatheter is where. So use cone beam CT again. We placed 2 microcatheter. One is more close to the shunt point. One is secondary. Secondary microcatheter is just in place in case it is in order to stop the reflux into the superficial middle cerebral vein as a kind of insurance, or and here is a ascending pharyngeal selection. So you see, if the shunt is close to the breaching vein. All the road in the world, usually the bridge is always, traffic jam. Because our brain, 100% of our brain, normal cortical venous drainage is draining through the breaching vein and entering to the main sinuses. The largest breaching vein in the human body is Galenic system, vein of Galen. So all this, breaching veins, but all this breaching vein is other normal function. If the shunt is close to this foot of vein, of course, as a consequence that, the clinical impact for the patient is so huge. So I conclude, the embryology is a fundamental and understanding the various anomalies and pathologies or cerebrovascular disease. And if we categorize only two, so don't think too much, don't think complex. We have only two types of dural AVF. One is coming from the neural crest-oriented dural AVF. One is from the mesoderm, and especially falcotentorial, which corresponding to the neural crest-oriented dural AVF is a malignant clinical cause, and as a consequence, we need definitely, absolutely indication for treatment. So I think that segmental susceptibility or vulnerability in terms of the formation of the dural AV shunt might be influenced by biological or hormonal factors associated with embryologically derived from bony structure or somehow germ layer, either neural crest or mesoderm. So we need a more genetically or molecular biological studies to elucidate and to study why that the dural AVFs only forms on a certain specific point. And years ago, that Albert Einstein mentioned, if you can't explain it to a 6-year-old boy, you don't understand it yourself. So that is my last slide, and thank you very much for your attention. And if you are interested with our activity, also this is a webinar, one-day webinars, and please save the 19th of July, next month. And if you take the QR code here, you can directly go into this conference webinar. And this year, we have a specific significant professor from Johanna Frozen from Finland. He's an expert about aneurysms, so because this year the topic is a functional vascular anatomy of the intracranial aneurysm. Thank you for your attention.
Michiro, thank you so much. So what a extraordinary lecture, impressive lecture. And I think that, gentlemen, we should start now to use the Tanaka classification for dural fistula.
Yeah, it's just simple. My view, okay, I respect the Bowden classifications and the Christoph Conyer classification. That's wonderful. And 30 years ago, they started this classification. And the indications of surgery or intervention can be also based on those of classification. However, if we are very more closely looking at the shunt points in terms of the embryology, it's so quite simple, and also can be divided only two types. One is a neural crested oriented, second one is a mesoderm oriented. That's it.
Very impressive. So I, for sure, I will use your classification. Michiro, thank you so much.
Thank you, Simone.
Just a comment. If we look at your cases, I think that nowadays we can say that for skull-based dural fistula, endovascular treatment is the gold standard. What do you think?
Yes. Yeah. Thank you so much. A very important point. Years ago, those of cases are sent to the microsurgery, but nowadays we can manage on the endovascular weight. If the tip of your microcatheter reach out to close to the shunt points, then you can eliminate whatever you have.
Yeah, and I think that one a key point is using the Conbin CT, that you are one of the masters. So I think that this new technology add a lot in terms of understanding of the pathology.
Exactly, yes. That is our kind of our driving navigator. So if you have a nice navigation systems, even you have a Corolla or a Lexus or Porsche, you can reach out the restaurant where you want to reach. But if you don't have this kind of Google map, you never reach out. The same thing.
Yeah, you're right.
For me, that the complexity is a kind of a Google map. Yeah.
You're right. So Raja, if you agree, before moving to the next speaker, I would like to share a couple of slides.
Of course.
Yes,
From,
please. Of course, my pleasure. Thank you.
Thank you.
Excellent.
Yes, it's just a brief summary. Can you see my slide?
Yes.
Yes, yes.
Is just a brief summary about our
Course. Huh?
yes, courses and initiatives. Yeah, that we have tried to offer to young people. The first one is SNAC, Surgical Neurovascular Angiography Anatomy course, that will be held in Rome at the end of October. Michiro Tanaka will be one of the faculties, but we have also Andreas Raber, Raul Kumar, Giuseppe Lanzino, Ed Ratz, Maxim Shapiro, René Chapeau, Takahiro Ota, and so many others. So if you are interested in to better understand the anatomy from a surgical point of view and an angiographic point of view, I would invite you to join us in Rome. The learning points are to master neurosurgical anatomy, to interpret it and apply angiographic findings, and we will discuss about the new endovascular devices. Another course is the ENS chronic subdural hematoma hands-on course in Rome at mid of September. We have 2 days regarding MMA embolization techniques with flow models, with brand new flow models, and just to understand how to occlude and the MMA and the best way to do this. Finally, I'm the director of the European Vascular and Endovascular Neurosurgery Master Course. Is open to specialists and residents in neurosurgery, neurology, neuroradiology. On the top here, you can see the QR code. If you are interested, it's 1-year course. We start on November, and is focused on practical training in OR and Angio Suite. Yes, we have 800 hours of clinical trial in our Angio Suite, 150 of theoretical lessons, and we have a zone courses during the master. Here you can see the list of the 12 hosting centers that will allow you to be trained in blue in endovascular, in red in open vascular, and in yellow in hybrid techniques. So we have centers all over Europe. Those are probably 12 of the most important European centers in terms of caseload. So the offer is very interesting. We have only 12 spots. Registration are open from now, and the course starts in November the 1st, and the deadline for registration is mid-July. So if you are interested to be trained in Europe, I kindly invite you to apply, because we have only 2 spots remaining. And last but not least, the NEVAD project is the neurovascular cases discussion. We have every 3 or 5 months this discussion. This is it's a true international discussion, because we start with Japanese colleagues and we move to China's, South Asia, Middle East, Europe, and North and South America. The next NEVAD will be on October the 1st, and the topic will be about AVMs and dural fistula. So it's perfectly fit with today's topic. And the idea is to present your case in 5 or 6 slides, and then we discuss all together. But the most important thing is that we are all, it's a discussion among peers, and we can discuss about Japanese experience through Middle East experience, till American and North South America experience. So I'm finished. Thank you so much for your time. I think that it could be very useful opportunity for you if you would like to join us. Thank you.
Thank you very much. It was indeed very informative, and of course, the sessions were wonderful. Dr. Liu, would you like to say something or ask Prof. Tanaka anything?
Thanks, Professor Tanaka, for a very nice lecture. Probably one question related to information of embryological or congenital type of fistula. And we found that there's a close relationship between venous sinus thrombosis and AVF formation. Do you think that the AVF is a congenital problem which was closed after development and reopened due to the thrombosis? Because there are cases that spontaneous resolution of AVF after canalization of sinus thrombosis. Your comment, Professor.
Yeah, thank you very much. Very important questions, and still yet not well understood or discovered. But in my view, vast majority of mesoderm-oriented dural AVF, which might be the transverse sigmoid sinuses or carotid cavernous sinus, can be related with in advance of the formation of the dural AVF, there are some sinus thrombosis. So sinus thrombosis may induce vascular genetic factor like vascular endothelial growth factor. Then this is a trigger of the formation of dural AVF. However, falcotentorial, so-called neural crest oriented, like cribriform plates or tentorial dural AVF, there is no significant, evidence that dural sinus thrombosis either originating then dural AVF formation. So not yet discovered. But in my view, as you explained, that most of the transverse sigmoid dural AVF can be related with acquired one. Thank you.
Thank you, Professor.
Thank you very much. That was a very novel, and Professor Tanaka's classification we'll look forward to being is it published in any journal?
Yes, already 2016 and 2019. Yeah, but most of the neurointerventionists or neurosurgeons in the world are not so interested with embryology. So still, Conyers classification, Bowden classifications is dominating in the world. But I think it's okay that, but just keep in mind that there are underlying something mechanism based on the embryology. Yeah.
Thank you very much. With that, we'll close the first session. Our second speaker, Prof. Yu Ling Chow. Prof. Ling Chow, are you here? You can start your lecture.
Good evening, everyone, and thank you for the invitation from ACNS. And I also want to show my appreciation for Professor Yuko Kato and Professor Bin Xu for their for giving me the chance, and also thanks to Dr. Raja for keep contacting with me. I'm Dr. Yingtao Liu from Shandong Provincial Hospital, China. I'm very sorry for the broken internet. And today's my topic is water exchange MR in glioma translational research. I'm a neurosurgeon, and specialty is neuro-oncology, functional stereotactic neurosurgery, and research focus is translational medicine of glioma AQP4. entities. My topic is the three parts, and the first part is we developed precise and specific AQP4 MR, and task two is we use this AQP4 MR to quantify proliferative activity and its primary clinical application. And task three is the inhibition of AQP4 to treat the glioma. It's our also exploration in the translational research and to find a new drug for the glioma. And first, I want to introduce about the AQP4, aquaporin 4. It is located on at the end foot of astrocytes, and it controls the water exchange. And usually, it is impossible to use a conventional MR to see to visualize the AQP4 because usually the MR resolution is around 2 centimeter, and also the detection limit, the concentration is very small, and so AQP4 is not fit for the directly visualized by the MR. So how can we find a way to quantification of the AQP4? So this picture, we can see the very fast flowing water, and we know there must be a machine underneath. So it's just like we developed the AQP4 MR. We use the AQP4 protein's function is a faster water exchange. We use this phenomenon, and this fast water exchange can be visualized by the MR. We all know. So this is the theory for the first stage technology, the AQP4 MR. So this is our first paper to develop a new model of DCMR, is a short speed DCMR, and there is a special parameter is KIO. It can quantify the fast water exchange in and out the glioma cells. In out the fast water exchange. So, and also we did the experiment from cell, animal model and human being to validate this short speed MR. The parameter KIO is have a very good correlation with AQP4. So the first is the cell line. We use this U87 MG cell proliferation cycle and showed that KIO and AQP4 and they have simultaneously expression pattern. And also on the rat glioma model, we also show that the KIO can visualize the growth of the rat glioma model, and we can see from the beginning it's very small, and with the time goes on, it's become big, and also the parameter KIO also become the pseudo color become higher from blue to red. So, and also the IHC AQP4 also showed that AQP4 have very good line correlation. And the next step, we use this DCMR to guide the glioma biopsy and multiple points. So from low to middle to higher. So, and also the AQP4 IHC also showed very good correlation with the KIO. the AQP4 expression have very good correlation with the image. So and the first stage result we published and at the Nature Medical Engineering 2 years ago. And also the editorial and the views thinks that it's a sensitive biomarker of proliferation of glioma, and also editorial thinks it's a new strategies is to use the DCMR because it can make the AQP4 protein visible. And so the next step, how can we continue our translational medicine? Because Ki67 index is a very popular biomarker used in the clinic to evaluate the prognosis, the treatment response, and also recently there are a lot of research focus on the Ki67 index prediction, use radiomics and artificial intelligence. But most of the papers research, they use multimodal deep learning, radiomics, and the image parameters and the Ki67 prediction is usually the mathematics statistics. So our goal and expectation is from multiple model to single parameter, and also from mathematics statistics correlation to physiological function linking. That our expectation is to use only one single parameter to precisely predict the Ki67. And also the research design is how to, from KIO, we use AQP4 as a bridge from KIO to Ki67. And we use the DCMR is the macro level, and the bridge AQP4 is use the IHC because they're synchronous, the co-expression pattern of Ki67 and AQP4. So we will have the chance to use a kind of MR parameter to see the proliferation status. That means from macro, through macro, we can through the macro expression, we can see the molecular status. Use big to see small. And can we get the Ki67 imaging from our AQP4 water exchange DCMR? So we also use the biopsy tissues. So we use the flow cytic analysis. We found that is the higher KIO points have also had a more faster cell cycle, and also at the low KIO points have more slow cell cycle. That means the high KIO, the faster cycle, the low KIO, the slow cycle. So from the primary analysis, we can see that is KIO have the direct relation with the cell cycle. And it's just our series from AQP4 to the proliferation is just like our IHC analysis that we use the antigen. Antigen is Ki67. The first antibody is AQP4. The second antibody is just a fast rot exchange, and we realized for HIC is DB. And for our research is MRKIO, that we can use the MR to see the molecular proliferation expression. And also we also use the experiment to validate our hypothesis that AQP4 DCMR can precisely captures the dynamic proliferation activity we use on the U87 cell line. That is, their change pattern is the same, nearly the same. They have very good correlation at the cell level. And also, we use the from cell and also to the human glioma biopsy, and also for the rat glioma model, we also showed that is the co-expression pattern of Ki67 and AQP4. And also, this is my stereotatic biopsy, and with my colleagues and assistant, and we showed that is the KIO. We use only the single KIO have a very good correlation, and is 0.92, even 1 centimeter. So this is seems it's a very good biomark, can predict the Ki67. And also we also reduced the redomics or deep learning, and we use a multi-parameter MR-based machine learning, and we found if we use only a single parameter KO is around 87, and standard very low, and standard plus machine learning, the best is the R square is 0.9. It's only 1% that we can see. That is KO is the very optimal new image biomark for Ki67. And also we showed the MR, that is we use only the KIO, the left side, is already very good. So we can use, that means the KIO imaging biomark is also a biomark for the Ki67 expression. And also we use our stereotatic biopsies from different points. That means here is low, here is higher. And also the results showed that is the lower KO, that with low Ki67, the higher is higher 67. And also we can see from the not only in the recurrent primary or the combination, they also showed very good correlation that between KO and Ki67. That means higher KO, higher Ki67. And this is our the second stage research published in Seronotics recently, and we found that AQP4 is a potential molecular connecting the MRKL with the proliferation activity. And also, we try to explore the AQP4 DCMR for clinical application, and I will show the audience some cases. And first is the global view of AQP4 MR, how we can use it. And you see the low KO, a high KO, and that means low exchange and high exchange. So that means we can use it to evaluate the grade of glioma, and also we can evaluate the treatment response, and we can use this imaging to guide the precise biopsy. And also we can use this image to monitoring the temporal spatial change of the glioma. So, okay, I will show you some application. So the first application is to guide the biopsy of malignant proliferative areas of the glioma, and we found the higher KO, higher Ki67, and the results showed that we can use this KO image guided had the best result and better than the large sample. Large sample usually during the operation, the operator will choose the sample for the pathological evaluation, and usually it's the standard. And during the past research showed that the stereo biopsy usually they will underestimate the malignant of glioma, but use our AQP4 MR that we found it can get the higher Ki67 values. That means it's a better way to guide the biopsy. And also we use this KI imaging that also means the Ki67 imaging. We use this forecast the super early TMZ response treatment. That means for the recurrent glioblastoma, sometimes we can still use the TMZ, but we don't know the treatment response. And this image can forecast the results at the super early stage within 7 to 10 days. And the left side is the treatment sensitive. That means after 1 week, it's become lower. And the second case is treatment resistance after one week is intermediate. That means some part is sensitive and some part still resistance. And the third patient, that means after 1 week, the imaging showed the become higher. That this patient is treatment resistance. We need to change the patient to operation, not continue the TMZ treatment. But for the first and the second, we can still use the TMZ treatment. And also, we validate the results from the patient that we can get 2 times biopsy. That means before the treatment, we get we get the results, and after the treatment, we get the conclusion that the patient is become more malignant. So we did the second, we did the operation and we get the sample. So we finished the IHC and showed that is the first time and second time showed very good correlation that the higher KIO imaging and also with higher Ki67. That means we can use this image to dynamically monitoring the treatment response. And also we use the KIO imaging that at the beginning and after the treatment, the 2 times imaging. We use a point-to-point Volkswagen subtraction, and we can see that is in this way the AUC can become from 1.6 to 0.9, and also we show that is different prognosis group have the different KL values. That means we use this subtraction method. It's quite better than the standard we use ROI, region of interest. So we found a new way how to predict the prognosis for the recurrent glioblastoma, even yes within 7 days. And also, and I think the biggest thing and the most important thing is if we can find a new drug to treat the GBM, the glioma, because it's very rare drugs is effective for this disease. So there's a new drug, small molecular drug is AR 270, and this is the inhibitor of AQP4. So we use this medicine and drug to find that it can inhibit the glioma proliferation very effectively, and the IC50 is around 4.5 macromolar. We can see it's from yes, it's the higher concentration and the more effective for the inhibition of glioma cell proliferation. And also we found the AR270 exhibits better inhibition effect against gliomas than the temozolomide, TMZ. So the AR270 at 4 macromolar and even at 4 macromolar have very good effect to inhibit the glioma cells. And also, just like the previous research on the biopsies, that is the proportion of faster cells cycles decreased, while the slow cells cycle increased. That means the proliferation cells decreased. So the AR270 showed a very good effect to inhibit the glioma cells, and much better than TMZ. And also we use this small molecular drug, AR270, to inhibit the GBM organoid growth. So we use the tissues from our neurosurgery patients, and we showed that this can showed that AR271, the product of AR270, can significantly inhibit glioma growth, even in rats. Okay, so we can see that we use this drug to treatment the rat glioma model, and 1 week we found that the treatment group have had a tumor decreased, and the control become larger, and the tumor volume reducing is by 2.5-fold. And experiment analysis showed that the AR270 inhibits the new DNA synthesis in the treatment group. That means the percent of cell produce new DNA DNA decreased after the treatment of AR 270, and is time independent in a time independent way. And at the beginning, I also showed that is. At the beginning, I showed that KI is a potential biomarker for KI67. It's an image biomarker. So if we use AQP4 inhibitor to treat the glioma, we can also use the KIO as an image biomarker to monitor the treatment response. So it's a very good way. That is, we can use a kind of image biomarker to monitor the treatment of specific target treatment by AQP4 inhibitor. So we can see this is the KIO changes with after the treatment, and the growth rate showed a significant line positive correlation with the KIO. So visualization and target AQP4 proliferative activity in glioma is a very ideal way. That means we can use AQP4 target therapy. Yes, it's a good way to treat. It's a new way to treat recurrent glioma, and we can also use our AQP4 imaging to monitor the treatment response. And okay, now it's my conclusions. We have proved that AQP4 is a potential molecular bridging MRKL with proliferation activity, and we found that the higher KL cells show high proliferation index, suggesting the possibility of special temporal proliferation monitoring. We propose a new technology for biopsy, treatment response, prognosis, prediction, and target therapy in glioma. And thanks for your attention. And yes, that's all.
Well, thank you. Thank you very much, Dr. Ling Chao. That was very interesting.
Thank you.
If I may ask you, is this drug currently in the experimental phase, the AER 270?
Yeah, it's a smaller molecular drug now, and at the first stage, the patent belonged to an American professor who got the Nobel Prize, but now it was bought. It was bought by the China pharmacology industry, and can be used in China, and also can be used IV. That means for the human being, but their first try is to use it to treatment the edema after the ischemic stroke, not on the glioma. But now we also got the patent, yes, to use this drug to treatment the glioma. Recently, we got the patent, so we will start the stage 2 clinical trials in our hospital very soon. Thank you.
Well, thank you. It was indeed very interesting, and we are all looking forward to this drug in future as a treatment for both cerebral edema and gliomas. Thank you very much. So far, we do not have any questions as of now, and so we can close this session. I will do it officially now on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both speakers of today, Prof. Michihiro Tanaka and Prof. Liu Ling Chao, as well as the chairs, Prof. Simone Pistillo, for the time and support for the ACNS webinars. A very special thanks to Prof. Shubin for broadcasting this webinar on the WeChat channel. And special thanks to Dr. Hui Pham and Dr. Liu Bun Seng for joining me today. Till we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.